Hello everyone and welcome to my YouTube channel. In today's video we'll be seeing on adenoids. Now what are adenoids? Adenoids are nothing but it's a collection of lymphoid tissue, okay? And they're also called as nasopharyngeal tonsils. So we already know that in our mouth or in our oral cavity we have some lymphoid structure which is called as tonsils. Now this is slightly different from them. Okay, so these are called the nasopharyngeal tonsils because they are present in the nasopharynx. Now, before we move into the topic proper, let's study a little about pharynx. Now, if you see pharynx, it is a fibromuscular tube and it is a cone shaped. Okay, that is, it is broader in the upper part, and as it goes down, it becomes narrow. Okay, so if you see, it starts from the cranial base or from the base of the skull or cranium, and it extends downwards. Okay, so down it attaches anteriorly to the lower border or inferior border of the cricoid cartilage. So somewhere here it attaches, or it stops here, and posteriorly if you see, it attaches to the inferior border of the C6 vertebra. Okay, so extends from the cranium of the base or cranial base to the level of cricoid cartilage and C6. So anteriorly cricoid cartilage and posteriorly C6. Now, if you see the path, okay, so it starts at the base of the cranium and it lies behind the nasal cavity. Then it continues downwards behind the oral cavity, and then it, one part of it, it continues as the larynx, and another part posteriorly, or it goes behind the larynx, and then it continues as the esophagus. So here, pharynx forms the upper portion of your air and food passages. Okay, so here you have behind the nasal cavity, behind the oral cavity, and then this is your larynx and this is your esophagus. So the pharynx continues down as the esophagus, and here the larynx begins here. Okay, so till this portion the pharynx has a dual function of carrying both the air as well as the food, and after that it goes into its respective pathway. So if you see the length, it is around 12 to 14 centimeters, and at the broadest area it is around 3.5 centimeters, and at the lowest area it is around 1.5 centimeters. That is where the pharynx continues as the esophagus, it is the narrowest. Okay, as we saw, the pharynx can be divided into three parts. So based on where it is located, it is nasopharynx, oropharynx, and laryngopharynx. So nasopharynx is nothing but, in brief, it is lying behind the nasal cavity. Oropharynx is here lying behind or posterior to the oral cavity, and the laryngopharynx. Okay, so this is the portion of the pharynx which is lying behind the larynx, and you can see this space. Okay, so this is called as the nasopharyngeal isthmus. We'll see more about it in the coming slides. So if you see the nasopharynx, so as we read earlier, the pharynx starts from the base of the cranium. So here also it starts from the base of the cranium and is the uppermost part, and that's why it can also be called as the epipharynx. So please keep in mind this word epipharynx can also mean nasopharynx. Okay, and start on the base of the skull, and if you see the lower portion or the lower limit, it ends, or it is demarcated by the soft palate. So wherever the soft palate is located, that is the lower border of the nasopharynx, or a horizontal line passing through the hard palate. So if imaginary plane is drawn, then this point, okay, from here till the upper portion, so this much is your nasopharynx. All right, now moving to the layers. Okay, so within outwards, so the first layer is the mucous membrane, then you have your pharyngeal aponeurosis, your muscular coat, and the buccopharyngeal fascia, which is the outermost. Okay, now mucous membrane, if you see in the upper portion or in the nasopharynx, it is ciliated columnar epithelium, and in the lower portions it becomes stratified squamous. Okay, and this layer has numerous mucous glands, and that's why whenever we have pharyngitis, this can lead to expectoration. Then we have the pharyngeal aponeurosis. This is nothing but a fibrous layer, and this lines the muscle coat. Okay, so this is thicker on the upper side or upper part, and then becomes lower as it goes down. Now if you see the walls of the nasopharynx. Okay, so the roof is formed by the basosphenoid or the basio-occiput. So the sphenoid bone and some parts of the occipital bone of the skull forms the roof. Okay, and if you see the floor, now imagine this has the mouth, this is your tongue here, and here is your palate. So the floor is formed by the soft palate. Okay, but here you see that it is discontinuous. So this is your nasopharyngeal isthmus, as we saw in the previous slide, and it is through this area that the nasopharynx communicates with the oropharynx. So the air enters into the nasal cavity, and through the nasopharyngeal isthmus enters your oropharynx and then enters the larynx. Okay. Now you see the posterior wall, it is formed by the vertebrae. To be specific here, it is the atlas. Okay, which is having its own fascia and the muscles. And anteriorly, if you see, now this is your imagine this is your front of the face, you have two nostrils, and the same thing continues uh, upwards and posteriorly, and here the nasopharynx communicates with the nose or the nostrils with the two openings again, which is called as the coena. Okay, and like we have the septum in the front of the face, the same thing divides this opening into two. Okay, so this is your anterior. Now if you see the lateral wall has the opening of the eustachian tube. Now this eustachian tube opens up in the ear. So here the nasal cavity or the nasopharynx is also connected to the ear via the eustachian tube. Now near the eustachian tube there is a structure which is called as a fossa of Rosenmuller, and now this is important because most of the CA develops or starts from this place. Okay, so this can be asked as an important MCQ question just for extra information. Okay, okay, as we saw that there's a muscle coat also. Now the muscle coat is having two layers. One is the outer circular and the inner longitudinal, and the buccopharyngeal is the external layer. Okay, so there are four layers, that is mucous membrane, pharyngeal aponeurosis, muscle coat, and buccopharyngeal fascia from inside out. And then we saw the important boundaries or the walls of the nasopharynx: the roof, the floor, the posterior wall here, the anterior wall, and the lateral wall. Okay. Now, this is also a very important aspect when we studied the nasopharynx. Now, whatever we see here is nasopharynx. Okay, so imagine if this surface is not there, you have your adenoids, and then you have your tubal tonsil. Again, this is present behind, and this is what we commonly see in the mouth. Is it's called as palatine tonsil, or just in general words it's called as tonsil. Then below the tongue we have lingual tonsil, and then in the sides we have something called as lateral pharyngeal bands, and in the posterior pharyngeal wall we have nodules. So these lymphoid structures, they form what is called as Waldeyer's ring. Okay, so this is again a very important question. It can be asked as MCQ or as short notes. Now moving into the topic proper. Now we know that these adenoids from this picture, okay, here the adenoids are present at the junction of the roof. Okay, so this is your roof and this is the posterior wall. So junction at the roof and the posterior wall of the nasopharynx. So this is the location, and it is subepithelial. Okay, so we saw that there are four layers of the nasopharynx. The first one is the mucous membrane, and it is lined by the ciliate columnar epithelium. So beneath this layer we have the lymphoid structure, and is present in the form of folds or vertical ridges, and in between these space, the space is called as clefts. Okay, so this is how your adenoids will be present here. Okay, now if you see, this is usually present at the time of birth, and this increases up to the age of 6 years, and after 6 years it starts reducing in size. So there's atrophy at the puberty age, and by 20 years of age usually this adenoids disappear. Okay, so this is the normal timeline of the adenoids. Now etiology, if you see why this particular lymphoid structure gets infected or enlarged. Okay, so normally we saw that it is subjected to physiological enlargement, so that can also be a problem. And in some children they have a tendency to generalized enlargement of the all lymphoid structures. So in that, even this adenoid becomes a part. Okay, and this adenoids come under the general category of MALT, that is mucosa associated lymphoid tissue. Okay, so because they are present in the mucous membrane, they are called as mucosa associated lymphoid tissue. Okay, so the causes can be recurrent rhinitis, sinusitis, or chronic tonsillitis. Even allergies of the upper respiratory tract can lead to the infection and enlargement of the adenoids. Okay, so these are the causes for the enlargement and infection or hyperplasia. Now the symptoms here of adenoids is not directly because of the lymphoid structure, but here it is because of the space. Okay, so we know that it is present at the junction of the roof and the posterior wall. So if this particular picture, if you see, this is a very narrow space, and this is how normally the adenoids may be present. If this enlarges, you can imagine what will happen. So it may become like this. So here the space either reduces or it becomes blocked. Okay, now because of this enlargement we have symptoms at the nasal, the oral or the ear, and general symptoms. Okay, now if you see the nasal symptoms, imagine this adenoids is infected and it is hypertrophied. Okay, so uh, what happens here is the normally air enters to the nasal cavity through the nasopharyngeal isthmus, enters the oropharynx and the larynx. Now if there's a block here by the adenoid hyperplasia, what happens, there can be an obstruction, and this can lead to mouth breathing. Okay, because here there is no place for air to go, so air enters from the mouth. Now because of this, what happens, usually this is seen in the kids, and this can interfere the feeding and suckling of the milk. Now, if the feeding or suckling becomes a difficult process for the kid, what happens? The nutrition level of the kid may drop, or of the child may drop. Okay, so the child may appear weak or appear dull. So that is one thing. So there can be obstruction which causes mouth breathing. That's the main thing. Second thing is it can cause nasal discharge. So what happens here? There is enlargement, and we know that the anterior wall, okay, here it is formed by the openings of the nostril which continues posteriorly as a cona. Okay, so here there is an obstruction, conal obstruction. Also there is associated rhinitis. So in rhinitis there is increased mucus production, and there is a conal obstruction. So if this particular adenoid was not enlarged, whatever mucus was produced here, it would enter the nasopharynx, oropharynx, and then it would enter the GI and move outside the body. But here, since there's an obstruction, there is no way for the discharge that is formed here to enter into the mouth, so it moves outside the nose, and we can see that the patient will always have a running nose or a discharge. Okay, so wet bubbly nose can be seen in these children. Next is because of the infected adenoids, it can lead to maxillary sinusitis. The reverse is also possible. If there's a maxillary sinusitis, it can cause infection of the adenoids. Another symptom is of epistaxis. Now what happens if there's a block here or obstruction here? Normally children start pulling their nose. Okay, so here because of or blowing the nose, so a repeated blowing of the nose can lead to epistaxis. We know that there is a area which is called as Little's area, and that is a very delicate region, and if there is any damage to that, it can cause epistaxis. Okay, so bleeding from the nose can also be seen, and a change of voice. So here what happens, the voice becomes toneless, and the nasal tone, okay, it loses the nasal tone. So whatever voice is produced, there is some element of the air that enters through the nasal cavity. It gives a tone to the voice. So if there's an obstruction, this particular quality of the voice, the nasal contribution of the voice is lost. Okay, it becomes a little heavy and toneless. So these are the symptoms which is seen because of the adenoid obstruction at the level of nose. Next we have the oral symptoms, or symptoms that is seen at the ears. So we saw that in the lateral wall there is a structure which is called as eustachian tube, and this eustachian tube, it connects with the ear. Now if there's an obstruction here, a kind of vacuum is created or a negative pressure is created, and we know that in the ear there's something called as a tympanic membrane. Now if there's a negative pressure created, the tympanic membrane can get retracted. Okay, so because of that there can be some hearing difficulty. okay, or a conductive hearing loss can be seen. Another thing is, because of the infection here, there can be recurrent attacks of acute otitis media. Okay, because if this is infected, this can transfer or can travel to the ears and cause otitis media. Now, if this otitis media, acute otitis media, is not treated, or if it is very recurrent, it can turn into chronic otitis media. So these are the symptoms which is caused because of adenoids at the level of the ears. Next, we come to the general symptoms. Okay, so considering that there is an adenoid hypertrophy and there's an obstruction, the child breathes through the mouth. Now, because this mouth breathing takes place, there can be some developmental problem at the level of the palate and the teeth. So there can be high arched teeth, palate, and crowding of the teeth because of the continuous mouth opening. And if you see, the face becomes expressionless. So here you can see there'll be sunken eyes, or the patient may appear dull. Then there may be absence of nasolabial folds, again because of the mouth opening. Then inactive allinesi. Allinesi is nothing but the fold of the nose. Okay, so as we breathe, sometimes there is some movement of these nasal folds, so this also becomes inactive. Okay, now one more reason for the child to have an expressionless face is because of the obstruction, the nose obstruction. The child finds it difficult to breathe, which can cause an interruption of his sleep, or the sleep may not be of good quality. So the child may be tired all the time. Because of that also, the patient may have a dull expression. Second thing is allergic shyness. Now, allergic shyness is this dark brownish appearance that is seen below the eye. Okay, commonly we see that people who don't sleep well, there is a blackish appearance below the or around the eyes. So that is called as here it's called as a allergic shiner. And then there's something also called as Denny Morgan lines or Denny Morgan folds. Okay, so there may be a kind of a swelling or puffiness of the lower eyes. So this is called as Denny Morgan lines. And because of the continuous rubbing of the nose, there can be a horizontal line that is seen at the lower level of the nose. So this is called as a nasal crease. So if you see anyone with a nasal crease, you can easily say that this person may be having recurrent rhinitis or upper respiratory tract infection or allergies, because of which there is itching and the patient rubs his nose and this particular line is formed. Okay, and also you can see rhinorrhea. If you inspect the nose, you can see that there is a mucus or nasal discharge that is present here, or even without examination you can see that the mucus may be just trying to leak out or running out from the nose. Okay, so this is something called as adenoid facies, a very important question, and these are the important features of the adenoid facies. Next, another general symptom is the pulmonary hypertension. Now, what happens here is, because of obstruction, the amount of air that enters into the lungs is less. Now, what happens here? The body thinks that there is not enough blood reaching the lungs, because in the resulting blood from the lungs, the oxygen level is less. So the body tries to uh, pump more blood to the lungs because it thinks that there's not enough blood reaching the lungs, and because of this it can lead to pulmonary hypertension. Okay, another thing is asproxia. Asproxia is nothing but the lack of concentration. As I told you, because of the obstruction there can be difficulty breathing and the sleep may not be of good quality, and because of that the general concentration attention levels may drop. Okay, now if you come to the diagnosis, on examination you might not find the adenoids, only if it is very greatly enlarged. Maybe it can be seen, the lower border or lower edge may be seen in the mouth, but usually not seen. So using a mirror, this particular adenoid hypertrophy can be checked, or a flexible nasopharyngoscope can be used to see the hypertrophied adenoids. Or you can order for a soft tissue lateral radiograph. So here you can see the enlarged adenoids. So that's all in this video. We just saw a brief on the pharynx, the anatomy, the layers, the walls, and the causes for adenoid hypertrophy and the clinical features with the diagnosis. So thank you for watching this video, and stay tuned for the upcoming videos. Thank you.